This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, welcome to yet another case of Phacomorphic glaucoma. She is an elderly lady, 75 years old. She has undergone iridotomy in the past, about a decade back for primary angle closure, and now she's presenting with this dense, mature cataract. This is the picture on slit lamp examination, and apart from the swollen lens, we also know that the antechamber is shallow. This is the OCT image. And this is the measurement of the antechamber depth on biometry. She was treated with topical steroids and anti-glaucoma medications. The pressures on the day of surgery were 18, but we have given her IV mannitol before shifting her to the operation room. The plan is to have the eyeball soft. Now, this is critical for two reasons. One, it reduces the risk of any suprachoroidal hemorrhage, which can happen in the eyes with the glaucoma, where the IOP isn't controlled. And secondly, if you have a softer eye, the rhexis becomes very controlled. If we have a soft eye, the Argentinian flag sign becomes irrelevant because most often than not, we can achieve a predictable good rhexis in such eyes as well. So the secret is to have a soft eye. So along with the IV mannitol, I'm also giving a peribulbar block and a massage. The goal is to ensure good akinesia and have a soft eye. Side ports are made, the capsule is stained. The chamber is pressurized by using dispersive OVD, which is a combination of chondroitin sulfate and sodium hyaluronate. One can also use a soft shell technique wherein underneath this dispersive OVD, one can use a cohesive OVD like the sodium hyaluronate. But in most situations, I find just using the dispersive OVD does the job pretty well. Why I prefer this over just a cohesive OVD is that it also coats the endothelium, stays in the eye for long, and the chamber maintenance is decent enough for me to have an uneventful rhexis. Of course, if you can afford, you can always use the cohesive OVD under it. But in my case, I just don't mind using just a dispersive OVD alone. The main incision is created. Time to perform the rhexis. The globe is stabilized with a pair of toothed Hoskin forceps. Note the position where I'm holding. It is held at the limbus, not in the conjunctiva, because the conjunctiva and tenions are very much adherent, very close to the limbus, so you get a good grip. So this is one small trick. And I avoid holding near the side port simply because if you hold near the side port, there's always a risk of pressing down on the posterior lip and the OVD escaping out. That results in chance of the AC shallowing. So to prevent all this, I would like to hold it away from the side port and preferably at the limbus. And care is taken not to press down on it. It's just holding and just trying to pluck the limbus. Time to do the rhexis. I'm using the Dr. Haldipurkar forceps. The capsule is punctured, the flap is raised, and I begin my tearing. So in the first 20% of the tear only, I will get an idea whether the rhexis is in control or not. Once if it's in control, I usually go ahead and do a single stage rhexis. I don't do the two-stage rhexis nowadays in most case scenarios. I feel I'm in good control, the rhexis is done. So we have a very good 5mm central capsule rhexis done. So time to deal with the nucleus. I avoid hydrodissection while dealing with these mature cataracts. It's not required. However, I'd just like to confirm the nucleus mobility. I'm going to use a chopper from my right side port just to nudge around and see whether it is free. Time to emulsify the nucleus. The strategy which I'm going to use in this case is going to be the direct chop technique. But I expect the nucleus to be slightly denser. So after removing the superficial epinucleus, I'm going to sculpt in the center, create a small central pit which would be around say 30% depth, which would give me access to hold the nucleus in the core, and then I would like to go ahead and try the vertical chop technique. See, the fundamental principle is to have a good hold of the nucleus, and this is possible and it is more relevant when dealing with extremely dense nucleus like this. The tip is buried into the substance of the nucleus. And because it's a dense nucleus, I want to achieve a good hold. So I want to bury the tip until it reaches the sleeve. So this ensures that my grip is going to be decent enough. So the tip is buried into the substance of the nucleus. I want to go as deep as possible until the length of the sleeve, and then the vertical chop is being performed. The nucleus is rotated and the next chop again is being performed. There is a loss of grip here. This is not the best grip which I'm getting here. So there's a slight torque, but nevertheless the chopping could be done. So this chopping maneuver is continued until we have about 6 smaller fragments. A note for the beginner surgeons: when you're trying to do the lateral separation, keep an eye on the extent to which the chopper is going to move. It should never come beyond the rhexis margin. So in our eagerness to achieve the perfect chop and lateral separation maneuver, sometimes we may end up tugging at the rhexis margin so much that it can split. Well, it has happened with me when I was in my learning curve, so be mindful of that. So what happens when you're learning, our focus is only on the thing which we want to achieve, that is lateral separation. In that process, our eyes and the mind escape the side effects of this exaggerated maneuver which can break the rhexis. So be mindful of that. The quadrants are now being emulsified. Care is to be taken that we emulsify in the right plane, that is preferably at the level of the rhexis margin. In this case, the chamber being a little bit shallow and the case being a little bit complex, maybe my emulsification plane is slightly anterior. I'm not sure about it. So the last few fragments are left now. The fragments are then rotated, brought near the angle of attack, and they're emulsified. A point to note here is that I did not stop during the entire surgery to put in OVD, which I would usually do and recommend all of you to do as well. So I thought it was under control and my process emulsification was happening in the right plane. So I did not replenish OVD. The rest of the steps are as usual. The cortex is aspirated. There can always be a risk of fluid misdirection happening in such eyes. So be mindful of that. I'm going to place a CTR in this patient simply because the lens iris diaphragm was pushed forward, which is an indirect evidence of maybe generalized laxity, which is not very evident, but nevertheless I'm going to insert a CTR into the bag. The bag is inflated with OVD, the CTR is threaded inside. Please note how my second instrument is hooking and supporting the CTR. This ensures that when threading in the CTR inside, there is no additional stress being imparted on the capsule margin as well as the capsule bag. With the CTR inside, as the time to implant the lens, the planned single-piece hydrophobic lens is negotiated into the capsule bag. OVD both in front and behind the lens is aspirated. The wounds are hydrated, and that's it, the case is done. Now these are the first day post-op pictures. You can see a significant amount of corneal edema. Well, this was a little bit surprising, and I thought this is because I have not replenished the OVD frequently enough when emulsifying the nucleus. The elderly patients, the endothelial health would be compromised. Although the surgery looked uneventful, maybe there would have been some mechanical trauma which probably could have been minimized by using the OVD a couple of more times than what I did the case. The cornea clears off over a period of time. On the 10th day, the cornea is very clear. The patient is happy with excellent visual recovery. The pressures are normal, and this is the post-op OCT picture. You can see the lens iris diaphragm is really pushed back. The angles are open, and for comparison, this is the pre and post-op picture. That's it. Hope you found this helpful. Thank you for watching.